Good morning, everyone, and a very warm welcome from the entire organizing team of CASML 2025. Today is all about India's leap into foundational models on day 3, a theme that captures the country's growing ambition in building large, impactful AI systems for science, engineering, and society. We have a wonderful lineup of speakers who will share how these ideas are taking shape across research, industry, and national initiatives. We also have a set of spotlight sessions later and in the day, and later we also have the Google workshops on TPUs. With that, let's begin our first plenary talk. Our first speaker of the day is Professor Phaneendra Yalavarthy from IISc. Professor Yalavarthy is a leading researcher in AI for medical imaging and serves as the Chief Project Manager of TANU, the National AI Center of Excellence in Healthcare. Please join me in welcoming Professor Yalavarthy to deliver the first plenary talk of day 3.
Thank you for that generous introduction. Once again, I would like to thank Professor Seshikumar for inviting me here. So very good morning to everyone. As introduced, I currently lead the AI Center of Excellence in Healthcare, and I'm going to give a little bit of introduction as we go along. This is funded by Ministry of Education. It is managed by something called a Central Project Monitoring Unit of IIT Jammu. And obviously we are located at IISc, so I'm thankful that it is happening here. And I just wanted to say, where are the AI Centers of Excellence which has been funded? And this is how the government thought process is currently, that there are 4 areas where they think AI can make a big impact. And all these 4 areas have been put as Centers of Excellence. So there are more to come. For example, one more to come is in the law. So currently, these are the ones which got announced: agriculture, sustainable cities, education, and healthcare. In the agriculture, IIT Ropar leads it, which focuses on digital agriculture. And sustainable cities, IIT Kanpur leads it. It is more of a smart cities. For example, those of you who dread Bangalore traffic, how do we do it with smart IoT devices, which looks after live traffic, air pollution monitoring, and things like that. And IIT Madras, which got awarded about 4 weeks back. So that is about the education. And it focuses on AI for all. In some sense, it is trying to bridge the skill gap which exists in the AI space. And we are in the healthcare space. I currently look after this AI Center of Excellence. And our focus is on non-communicable diseases. And I'll tell you a little bit more about what we do, what kind of solutions we are bringing out. Again, it is not alone me. There are a bunch of faculty who work in this. So a lot of the work I'm presenting here is also based on a lot of their work. So I'm also going to tell you who are those groups are. Again, just to reiterate, it is an AI Center of Excellence in Healthcare funded by Ministry of Education. And we are operated as a not-for-profit Section 8 company. So that means that we are kind of independent of IISc, but we are promoted by IISc and we are located in IISc. In fact, if you want to visit, it is exactly on the other side of the road where you see a Sense building. Right next to the Sense building, there is something called as TCS SmartX Hub. So we are located in the 7th floor of that building. And it is not a shareholder company, it's a company by guarantee, and it is given by IISc. Again, just to give you a little bit, if at all you work in the healthcare, so ethics becomes very, very important. So we strictly follow something called as ICMR approved institutional ethics board. That means that all our data collection, all our solutions are ethically approved ones. And we will follow strictly DPDP Act of 2023. So those of you who doesn't know, it is a data protection and digital privacy bill that I got introduced for India. So essentially to ensure that you have a privacy for it, and we also follow that. We are not a data fiduciary. That means that we really don't aggregate the data sets and try to monetize them. So we are more of an AI solution developers. We work with a lot of medical partners. This slide is going to come back again when I talk about a lot of in the end. So just to give a little bit of journey of ours. The award of AI Center of Excellence came in June 3rd. And it has a funding outlay of 310 crores over the next 4 years. And then we got the name registration done under the Ministry of Corporate Affairs. We got the Section 8 company registration done October 3rd. And as we are all, so we also apply for some private funding, and we got the first private funding from Google. where we are awarded $2 million. So that happened on November 28th. So again, I wanted to come back to this and then show you a little bit of this, but I wanted to point out that where is any of you who are interested in the AI and who are interested in the private investment into the AI, I would request you to look at something called as AI Index Report. This is released every year. And for example, it got released for 2025, which looks after the investments, which looks after the trends. For example, in the medical and healthcare, the pink line you see is for 2023, the funding given by private investment. And 24 is the blue line. And you see that there is a big quantum of jump in the funding. But then you zoom out and look at it from 21 till now. So what you will observe is that the funding has been kind of stagnated or capped at 11 billion. And it is not linearly growth. It has grown until about 2021. And after that, it is kind of oscillating with a cap at 11 billion. So this is primarily because the honeymoon period of AI is over, and then it has to show really it works in the deployment. We call it as deployment. Deployment means that mainly it works in the clinic. And this is a study which was done last year by Journal of American Medical Association, where they looked at, where is the AI coming out to be in the tasks. And what you will observe is that, that this may not be so much visible for the back people. What you will observe in the bottom is the dimension of evaluation. So where AI got evaluated as an accuracy metric, so that means that you say that whether AI is as accurate as a clinician, for example, in making the diagnosis. So that is the second row you see there. And what you will observe is that there are more than 100 studies in that. Oops, something happened. Okay. So what you will observe is that there are more than 100 studies that have happened on making the diagnosis, which has evaluated the AI accuracy. But you go down and then look at in the deployment, in the clinic, how many studies were done. Really, was it useful in the clinic? Was it able to do it in time? You will see that in the making the diagnosis, there are only 4 studies. So that means that roughly 4% of the AI solutions move from POC to what we call it as deployment in the clinic. So this has been the major problem. That means that we are still not able to find a value for the AI part. So that's why the funding is also, or the investment part is also not really growing. And as a Tanu, as a AI Center of Excellence, our focus is on that deployment such that we can focus on this. And in this segment, we primarily look at AI-based software as a medical devices. So again, we are a device agnostic. So that means that we develop these solutions as a softwares. So which are like applications which can reside in edge devices or even in the hospital information systems. And we are interested in effective management of these non-communicable diseases. I'll talk about it in a while. And we are interested in point of care. And our focus is on non-communicable diseases. And then we focus on primary care. So when we focus on, I will also tell you why primary care is important and then where are the difficulties or challenges in this. So let me start off on the non-communicable diseases. So this is the chart of the number of diseases or the major diseases which were causing death in 1990. And what you will observe is that on the top there is something called as infectious diseases. So whereas when it comes to now this year, like 2021, which is roughly about 11 years late, but 30 years later, what you will observe is that non-communicable diseases like cardiovascular risk, diabetes are the leading causes of deaths. In fact, we argue saying that about currently 70% of the deaths in India are accounted by NCDs, right? And then large proportion of them are preventable, large proportion of them are manageable. So that's why we want to focus on that part that, can we do early detection? Can we do something of the effective management using AI? And so this is something called as care delivery. Once you are diagnosed with non-communicable diseases, for example, like the common one I can tell you is like diabetes. So once you are diagnosed with diabetes, there is something called as a care which has to be given continuously. So for example, you are diagnosed with hypertension, then there is also care delivery which has to happen. So how does this whole process work? This is what we call it as care delivery system. So there are general population, there are individuals at risk, and then they try to seek a care. When we say they try to seek a care, this could be a health checkup which you attend, or this could be door-to-door campaigns which government do. This could be health camps which are run by NGO or the government. You just walk into that and then suddenly you find that your blood pressure is high or your glucose level is high. So this, how do you find out that, their blood pressure is high or glucose is high or somebody is having a early cancer signs? So that is done by what we call as point of care. And then typically they do preliminary diagnosis. For example, like in the diabetes case, a lot of you know this, you can do a prick, right? So there is a strip and then you do a prick and then that is how what it shows you. But the problem is that is not confirmatory. So then once this only gives you preliminary diagnosis, then they move up the chain, they come to a community center or a district center. For example, in the diabetes case, they do what is called as capillary blood glucose level. So that means that they draw the blood from the capillary and then they test it. That is a gold standard. So in some sense, we want to build our AI solutions in the realm of this point of care such that we can empower something called as non-physician healthcare workers. So because at the point of care, what you observe is that all these nurses and ASHA workers are the ones which kindly which are the ones which are looking after the care. So we want to empower them with AI solutions. So in some sense, they don't have the specialized knowledge. For example, the solutions we are planning to bring in include for oral cancer, breast cancer. So they may not have that specialized knowledge for them. And then they also have resource constraints and they also don't have diagnostic tools. So because of that, we want to bring in AI to them. And then this is what we call it as our strategy in terms of this. So as you know already that, AI kind of approximates a function which you are planning to have, right? So some sense, if you have a ground truth, AI is an approximate solution to that ground truth. So the ground truth we have is that what we call it as the physician expertise. So that means the doctor expertise is what we want to emulate or approximate using AI. And then this solution is what we want to give it to non-physician healthcare workers like nurses and ASHA workers, such that we augment their knowledge, such that we empower them with AI, such that they can do a better diagnosis. So this is the whole thing. So you have the healthcare system. The training data we are going to use for all the AI solutions is coming from the doctors or the physicians. And then we have the tool development and then we integrate into the primary care systems. And then hopefully it will improve the primary care system as a whole. And then again, those of you who doesn't know what is primary care means is that it's essentially like, what currently under the government, which is called as Ayushman Bharat Wellness Centers. So these are all primary health centers which have very limited resources. And again, so there are resource constraints in terms of primary care. They have a very tight budgets. And more importantly, the primary care is mostly given by non-physician healthcare worker. So that means that, for example, if you think about ASHA workers, the qualification for ASHA worker is 10th pass. So they don't have that knowledge which you are expecting them to have. So that means that the solution you develop should be very easy to use, right? And then and the primary care also has a lot of errors because there is a lot of data heterogeneity that happens. Because you are really in the field, you are in a center which has a large number of patients coming in. You cannot guarantee that the data you get will all be good, right? So in some sense, you have to also do the quality control or quality management aspects as a part of the solutions. Again, what are the solutions? I'm going to go over each one of these solutions, but the solutions we have is starting from oral cancer detection, breast cancer detection, retinal care, diabetes management, and mental health. I'll talk about each one of them. And each one of them are led by one of the faculty members which are located in IISc. So I'm going to talk a little bit more about these solutions. And before I move to the solutions, one of the important things, how healthcare becomes different compared to rest of the fields is that we have one more layer of regulatory. So every solution that comes into the healthcare has to be regulatory approved, right? This is called as licensing. And the licensing currently in India is given by DCGI or CDSCO for that matter. So there is a medical device licensing which you need to get. It is called as ABCD type of things. So in a very, very simple sense, we start from the data collection. I think you know the pathway. We do model development, then we do model validation. And then we want to go for the certification or licensing. And once the license is there, all our solutions are going to be put in a platform. We call it as digital public infrastructure. So it is like Aadhaar or any other DPI which you use like FASTag or even DigiLocker. So it's going to be, we are going to develop a DPI and we are among all the 4 COEs, we are the COE which are leading the effort in terms of developing the DPI for AI. So that means that it is not only our AI solutions that will go into this platform. It might be other players, other entities which have developed AI solutions in this space of healthcare, sustainable cities, education, agriculture that might go into this platform. Let me go into one by one details about this. So the first one, the first solution I'm going to show is the most advanced one among all the solutions we are planning to develop. So it is called as AI-enabled point of care for mobile phone-based oral cancer screening. India has 1/3 of the global burden of the oral cancer, and that is largely due to a lot of our people eat or chew something called as tobacco quid, or they chew archaea nut or archaea nut quid. So that means that is like a pan which people eat, or the gutka which people eat. In fact, chewing archaea nut is not dangerous, but chewing archaea nut with any of the quid, right, like sunna, where they call it as, like chuna, you put it, that is the more dangerous one. So, and this leads us to what is called as pre-malignant lesions or precancerous lesions. Can we detect them early? So what we have is a simple mobile phone based one. So where healthcare worker will go door to door and will take 8 pictures of the oral cavity. So that is they ask them to open the mouth and they take 8 pictures of it. And the picture, once the picture is done, this model runs in the mobile phone without any connectivity. It's a natively running on the mobile phone. It's a very, very lightweight model. And it has 3 things to do. One is that if it doesn't have the quality for the image, it will say that retake the photograph. And if it finds anything suspicious, it will say that it will refer it. So remember, I told you that in the NCD care delivery, it has to refer that and go up to the higher level. So the confirmatory test is done by biopsy. So that means that they have to go to a district center or a community health center where they can get a biopsy done and then make it positive. And otherwise, if it is not positive, it will do a routine follow-up. In fact, this got deployed in across 9 sites and then across 6 states. In fact, if you don't want to use AI, so then there is something called as oral visual examination, which the healthcare worker needs to do. So that means that they need to be able to identify what is a pink pigment is versus white pigment. They need to know the texture of the lesion to identify whether it is suspicious or non-suspicious. So that is again a very specialized knowledge. Typically oral radiologists or dentists are trying to do it. So we are trying to bring that down to ASHA workers and nurses level. So using the AI. And again, so it has won many awards, but the recent one is in the Indian Mobile Congress. The app is called as Arogya Arohan. And in fact, you can install it and then get it done. We have not yet got the regulatory approval yet, but we are hoping to get it. And again, it's an app which got the award under the educational institutions recently. And the second problem we are working on, our second solution we are planning to bring in, is in the breast cancer space. So currently breast cancer has kind of guidelines. So WHO says that the guidelines is that clinical breast examination is needed for those which are resource constrained. Clinical breast examination is nothing but you palpate the breast. Palpate means that you press the breast and try to identify whether there is any lump in the breast or not. And the resource rich one, they can get a mammography done. And our own government guideline says that those who are above 40 should get a CBE done. CBE is clinical breast examination done every year. And those who are above 50, they should get once in 2 years mammography and every year CBE. So this is what is our guidelines do. But they say that this is only for normal population. Those which are at higher risk should get every year a mammography. Now, but how do you determine this risk? What do we do for the risk determination or risk prediction? So there is a little bit of gray area there. But let me just point out what is the current gaps that exist. So SBE or CBE, SBE means that self breast examination. So you don't need to go to clinic to do it. The patient themselves can do the palpation and then find out this. So there was a survey done by the National Health Authority saying that how many people have done at least one SBE or CBE among those who are above 40. So hardly one CBE and SBE in their lifetime. I'm not talking about every year. So it is about 15%. Right? Less than 15% of the women who are above 40 years, there are 21 crores such population. So have done at least one CBE or SBE. And mammography, again, we have 2,000 machines available throughout the country for a 21 crore population. Again, there is a large gap that exists. So there is no way, if every one of them has to get a mammography, there is no way we can do it as well. We don't have the machines. Even if we try to procure it today, and if you try to, ideally we should have close to 40,000 machines. If you want to make it to 40,000, it will take 4 years for us to do it. So it is also not viable, and then it is not really doable. So current uptake of any breast cancer screening is only in the urban population. The urban accounts for about 0.9%. About, you can argue saying that about 1% population go through this, what we call it as the screening process. And in the rural, it is actually 0.26. So 0.26% of the population which are above 40 who are women are getting any kind of screening done. So this is a fundamental problem. So there is a huge gap that exists. So there are a lot of alternative solutions that are coming up. For example, thermography based screening. So if you have heard Niramai, which is also IISc alumni incubated startup, they do thermography based one. Again, it is not meant for low resource settings. Again, it does some gap filling, but it is not meant for low resource. For example, today Niramai one will cost you around 1400 to 1500 rupees depending on how you look at it to get thermography done. And there is ultrasound which you could do easily, but then still it is an adjunct, it is not confirmatory, or even it doesn't fall under what we call it as point of care. And MRI is another one, but again it has the same problem as the mammography machines. It's prohibitively expensive. So what does the rest of the world do? So for example, in a lot of these cases, one thing is certain is that you want to know the breast cancer, what we call it as prediction is, or a risk prediction is. We call this as risk prediction. So there are models which are available, which looks at menstrual health, reproductive health, and they also look at the family history and predict the lifetime risk of somebody having a breast cancer. And what we wanted to do is that a lot of these models, which are like IBIS or Gale models, they ask questions like, did somebody went through hormone therapy? And ethnicity plays a major role in these models. For example, if you are African American woman, so the risk goes up quite a bit. So most of the models are Western. There is nothing which is Indian in this sense. So what we wanted to do was that develop a questionnaire which is very, very Indian based, so that we can do this risk prediction very well. So that means that our idea is that we wanted to do like a hierarchical. So where we want to do the risk prediction based on the questionnaire, and those which are at high risk can be referred to mammography. Again, this has to be speech to text such that the questionnaire we are filling in becomes very, very easy. And the healthcare worker is only, once they have speech to text, they're confirming that, whether the text which has been come out of the speech is accurate or not, so that they don't need to type in anything. And then it becomes very, very easy. So in some sense, at the bottom, you have a conversational AI, which is actually screening the population and giving you the risk. And those which are at high risk are referred to mammography, such that the 2000 machines we are having were effectively used as well. So this is the solution we have, and we already have the questionnaire. It has about 22 questions, and it's one of the first fine-tuned Indian questionnaire. And it also can include SBE and CBE. If you have done SBE or CBE, it can also include those results as a part of the questionnaire. And it is there in 9 Indian languages. If you are interested in, you can go and look at it. And it provides the lifetime risk of the breast cancer. And then there are inputs from 4 breast cancer specialists, 2 from AIIMS and 2 from Manipal, who have participated in this questionnaire design. What else we could do? I mean, this is another thing. So where we are, those which are at initial phases, what we are planning to do is that everybody will do both the questionnaire and mammography. So if you combine both of them, could we predict in 1 year what is their risk of getting breast cancer? So this is a multimodal. We can use any of the vision language models. So currently, most of the models that exist in the area use something called as heart encoding. So we want to change it and use vision encoding, vision language model to do this risk prediction. Of course, it's a longitudinal study. We have to collect the data for the next 4 years and then try to develop these models. And again, on the retinal care, I think you'll find many solutions that exist. But in the retinal care world, you look at the fundus image and try to determine what is the problem in the fundus images. And most of the solutions tend to be very narrow. When we say very narrow, one AI solution will be able to detect diabetic retinopathy. One AI solution will be able to detect glaucoma. One AI solution might be able to look at age-related macular degeneration. We call it as AMD. So each one of them requires a separate models to be run. So can we develop one foundation model like an ophthalmologist who will just simply look at the data, look at the AI will look at that fundus image and then say what is wrong. It could be a cataract, it could be AMD, it could be glaucoma, it could be diabetic retinopathy. But we want this model to run out of what we call it as edge device. So that means that this model should be able to run natively on a mobile phone. Remember, a lot of the things we are talking about so far, because we want to be in the primary care setting, we assume that we don't have connectivity. Our connectivity is extremely limited. So we try to run all the models natively. So these are all lightweight models. So what we want to do is that we have a fundus image capture, and most of the fundus cameras come with Wi-Fi or Bluetooth enabled. And because of the Bluetooth and other things, what we have is that we can transfer that to the edge device and do the processing and give all the findings, so that it does a quick triaging of things. And remember, anyway, the final diagnosis, they have to go to a tertiary center and then get it done. And other thing which we are planning to do is that what is diabetes management tool is. So the diabetes management tool is that currently most of the diabetes management is purely based on glucose level. Could we include other biomarker? Could we develop a clinical decision support system for the nurses to nudge? And so this becomes more of a management tool. And on the mental health, what is going to happen is that today mental health is the most, what we call it is most sought after solution, which everybody is looking for AI to give that solution. Because most of the humans are more comfortable in talking to a machine rather than to another human. So we have some things like depression, substance abuse, dementia. So these are all the ones which we want to do, and there are standard questionnaires which are available. But how do we integrate into an AI solution so that speech to text becomes very easy? And we also want to integrate into National Mental Telehealth Helpline. So that means that those who talk to National Mental Telehealth Line, so then automatically go through this questionnaire in a voice interactive system and then get diagnosed for that. So that is the pipeline we have. So where are we in terms of all this? So oral cancer, we are already at regulatory approval. Retinal and diabetes, we are having some model validation going on. Breast cancer and mental health, we are still at ethical board approvals. We are yet to do this. But having said all that, I just wanted to point out that at the bottom level, right now we are looking at low cost, low latency solutions which are running on edges. But as we move along, we want to build refining models, right? Might be foundational type of models, which can serve the tertiary hospitals, which at the end, which has high cost, high refining of the diagnosis. Right now we are telling yes or no. We could give what is the stage of the cancer, for example, stage of the disease as well. And when we collect all this data, we also want to develop health foundation model, because anyway we are collecting all this data. We can build that. And then as a horizontal, you would have already observed that we have a conversational part almost in every vertical we are having. So we want to do that as a horizontal. It's a multilingual conversational chatbot which is meant for healthcare workers. And then we also want to develop the AI platform which will serve as the DPI part. So this is the team I have, and then these are the faculty members who contribute to this. So I'm very thankful for them for being part of it. So this is the executive team, and here are the medical partners. And I'll stop here, and I'll be happy to take any questions. Thank you.
Thank you, Phani. Wonderful talk, and as well as the overview of what AI is doing in the health sector as well. So now it's time for 1 or 2 questions. Yeah, maybe the first question and the second question, third. 3 questions let us take here.
So I work in public health delivery. One question I have is, you focused a lot on diagnosis. When it comes to treatment recommendations, there is a risk that LLMs trained for Western populations, the advice won't fit very well. And so do you have a focus on treatment beyond diagnosis? And another question, just a second one, since I have the mic, is you seem to have deprioritized maternal care and early childhood care. Is there a reason for it, or would you be looking at it?
Okay. So both are good questions. Let me start off on the first question. So we are not into the care delivery part, if at all you ask me, because the reason is that primary care is the one which is most neglected. No company would like to invest in that space because there's no money in it. And we as a government entity, our focus is on that. So that's the first part I wanted to mention. That's why we have focused only on the detection part, right? So, and not that we are not interested in the other parts, but the only thing is that no company is putting their money or developing solutions in that space, which is very much required. And also remember, we are a health worker facing app. We are not a patient facing app, right? So it is used by healthcare workers as a recommendatory systems. So that's the first part. And why we are not focusing on RMNCH? So the RMNCH is a well-studied area, and there are already bunch of solutions that exist. So we wanted to focus only on these 5 solutions because that is where our focus is on, right? So of course we can argue saying that why we are not doing cardiovascular, which is the biggest risk. Forget about RMNCH. We do fund few other entities in that space. Right, what I'm not talking about is that on the cardiovascular space, we fund JIPMER and as well as KMC Manipal to find out some solutions. In the RMNCH, we fund like AIMS to develop certain solutions. But we when I say we, at IISc, we are only focusing on these 5 solutions. As a center, we do that.
Yeah.
Hello.
Quick question. Yeah.
Hello.
Yeah, you're audible. Go ahead.
Hello, I am Sutirth from IIT BHU Varanasi. My question is, there are in heart disease recognition or diagnosis, we have like ECG data, and we have MRI images for brain and other parts as well. So from where we can train the AI models like CNN units for do the semantic segmentation and detect tumors and all those things. For heart disease as well, we can do the time series analysis. And these analyses can be integrated with the system from which we take the MRI images or we do the ECG analysis. So I see a large gap, like the images are not digitized, and from there we don't get the data set to train a model as well. So what is your take on it, and how are you thinking to make a device that can be integrated with these type of diagnosis devices and can and it can automatically give the diagnosis?
Okay, so currently we don't work in that space of those. But having said that, so we call this as interoperability. So in the sense that you get images or you get the data from X, and then your solution should be able to interoperably take their data and then give the diagnosis or give the analysis of those. Currently, this interoperability is the biggest cost which exists. So again, those of you who are coming newly to the healthcare, so $1 is what we do for developing the AI model, and $99 is what we spend in integration. So we call it as deployment / integration. So this is the fundamental problem of healthcare, and unfortunately, healthcare is the only field I can point out saying that when you introduce technology, it increases the cost. It doesn't really bring down the cost. So this is the fundamental problem we have, and I don't have any solutions for it. It is universally true. I mean, not only in India, but it's across the world. This is true that healthcare is a very, very complex, because one is that it has a regulatory part. Another is this integration or interoperability being a biggest issue.
Okay, I know there will be many questions, but in the interest of time, and we do not want to go further. And as he mentioned, right, so the center is the next building. If anyone is further interested in AI for health or AI in health, so I request to visit the center, a center of excellence in the next building. You can approach Phaneendra also to get a question and interact with him. But before that, just a small token of appreciation. So I would like to give a small memento to Professor Phaneendra. Okay, so let's thank the speaker once again. Yeah, thanks, Phaneendra.